Good afternoon. It's Matthew Holt. I'm the publisher, founder, head guy at the healthcare blog. This is THCB Gang. We're back. We've been away for a few weeks over the summer, bit of vacation there, a bit of a trip to HIMSS. And but the team, a bunch of the regulars are back. Really looking forward to this session. And I'll quickly run through who I've got today. Michael Millenson from Health Quality Advisors. Casey Quinlan, who is back with some great news of her own and now back and working in, mighty Casey. Anish Koka making a relatively rare but very welcome appearance on the gang. My co-host of Health and 2.0 and the host of WTF Health, Jessica DaMassa, and our friend medical historian Mike Magee. So here we all are. We're live and up, and Casey, you seem to be living in a fishbowl. All right.
So I did live in New York for almost 30 years, and that's very like that. So right. Yeah, sure.
So let's quickly, as some of you haven't seen you for a few weeks, Casey, let's just check in on you and how you are doing.
Well, first, I will say that the background, I in my life have been a scuba diver since I was 16, which is a little while ago. And I was also a scuba instructor for a number of years. In fact, I still have my rating. But I haven't taught in a long time, so that I come by that legit. Anyway, and so I'm wearing a Hawaiian shirt in honor of the fact that this is sort of the I think almost the last one. There's one more next week before or anyway, Labor Day is coming. We'll just put it that way. So summer's almost over, but it's really not. We never got hot vax summer, did we? Did we get that? We didn't get that, and I feel cheated. But one thing I do not feel cheated about is having progression-free scans on Monday around my stage 4 breast cancer recurrence. Yeehaw. So it's been a pretty good week. I've been busy. I'm feeling really good. And my mobility is pretty good, considering that I could barely take 2 steps in June. So #winning. And I'm going to my first conference in outside of my house, not virtually. I'm actually attending in the room a conference in Boston in later September, but I'm wearing all the masks and taking all the Purell and putting up like a set of shields around me. And I got my 3rd jab of Pfizer, so I'm good. Anyway, how are you guys?
That's all great to hear, and very exciting. I wonder if that conference will happen. I'm still a bit dubious about how we go. All right. Well, let's. I just noticed I haven't been. My background is adrift, so I will go around the room, ask people ask people what they've been up to the last few weeks and what they've been noticing, and I'll go fix my background because I didn't know anything. All right. Why don't I start with you, Jessica?
Like your shirt there, Mr. Holt. That's very nice.
I thought you liked my shirt.
Yes. Hey. So yeah, I've been up to a lot of interviews. Had a big one yesterday with the CEO of Headspace, CC Morgan, and the CEO of Ginger, Russ Glass, as they announced their merger. So that was a huge conversation for me to be a part of, which was awesome. That's that business is worth $3 billion combined. They're going to take over mental health care with a full spectrum of offerings and hopefully bend the cost curve there. That's the phrase I actually kept hearing over and over again in that interview that seemed new to me was cost-effective, affordable. So it's like they're really hot on trying to figure out how to make Ginger's coaching and therapy services, which I guess are known as the lower cost option in that range of options that exist out there. And then strapping onto it the meditation and mindfulness stuff that Headspace sells directly to consumers and combining that offering into something that can help put people into the right type of mental health care for their acuity level and follow the cost effectiveness rabbit hole as they do that. So yeah, I've been up to stuff like that. That's it.
That sounds fun. We'll come back to your other interview of today, which I'm not sure is going to be quite on the same cost effectiveness level. We'll get into that, but the mental health one is pretty interesting. And that market is both exploding financially and consolidating, and is still frankly a mess, right? All the above. Michael, what have you been doing the last few weeks? And what have you been
well, I'm working against with quality and safety and a few projects that I'll talk about if they come to fruition to actually try to, shake things up. But, following, of course, the Delta variant, and what's interesting is how much is happening that's not the Delta variant that we're not paying much attention to because it's not a screaming headline. Like the Medicare, the whole infrastructure and bill that Biden is doing that's going to add to Medicare benefits, is going to expand Medicaid, is going to throw money into home care, incredible things. But because it's not a healthcare bill and because we're consumed properly with what's happening with the pandemic, it's not on the horizon at all. So it's kind of interesting to see what's happening. Personally, I'm still looking at patient safety and noticing that it is nowhere in terms of the priorities because we're busy again with workforce safety, right, without the vaccine and everything, which I completely understand. It would just be nice if, in the absence of pandemic, we thought about protecting patients as well. So a lot going on, which, as we all know, is kind of confusing, and we shall see.
Fantastic. Anish, what have you been up to the last little bit, and what do you think? I'm looking forward to your views about where we are in the case of the vaccine, the mandates, the crisis in Florida and elsewhere. You might have an interesting view on that.
Yeah, it seems like we're kind of drenched in it, and it seems to never end. There's a I've been particularly interested as I'm a cardiologist, and I've been I'm pretty clinically busy, kind of see patients 5 days, 7 days a week. And one of the things that's been interesting to me in terms of the conversation about vaccines has been the signal that we've seen of myocarditis in young men. It seems that there's a pretty high, there's a much higher rate of myocarditis with the mRNA vaccines, which is inflammation of the heart muscle. Basically, you after your second, it's typically seen after your second dose of the mRNA vaccines within 5 to 7 days. Multiple different databases now have reported that there's higher rates of people having symptomatic myocardial inflammation that results in them going to the hospital and being hospitalized. And that's been seen in the Israeli registry. It's been seen in Canada. And then just yesterday, FDA had an analysis of Optum claims that also showed a 1 in 5,000 rate of myocarditis in young men. So, and it's been really interesting just seeing the conversation. I'm interested to hear what people on the panel think, but it's been really interesting to see how that's framed, because it almost, if you bring that up, you're very quickly labeled in the Twitterverse, at least, or in other places, as being anti-vax, because anything that kind of goes against or would kind of caution, or I view it more as informed consent, right? It's if you're talking to a 17-year-old, a parent, or the 17-year-old themselves about the vaccine, it's something that I think now I've been mentioning now for about 6 weeks or so. So that's been a particular interest of mine because, again, I'm a cardiologist. Overall, the other point that has been somewhat interesting is kind of seeing how public health views different things when it comes to things that we think will help the pandemic. So particularly the view towards community masking in terms of the level of evidence and the strength of support for that versus something like monoclonal antibodies that are given to the high risk to kind of prevent them from progressing. That's when they're acutely sick. And it sure seems to me, as a cardiologist who kind of spends a lot of time looking at papers and seeing, all right, is this good, or is this intervention make sense or not? What's the level of evidence? From wearing that hat and looking at the evidence for community masking, it seems a heck of a lot weaker than the efficacy of monoclonal antibodies to the high risk to prevent hospitalization. Yet I've seen multiple public health officials kind of poo-poo these monoclonal antibodies. Oh, it's pharma-driven, profit-driven, et cetera, and then just kind of wholesale go into, saying masking. That's what we're going to do to finish it. So those are the two interesting points that I'd love to hear some discussion about.
Yeah, that's really interesting. I mean, I think there's those of us who've been very much on that, well, when the vaccine arrives, it's going to fix it all, now and have certainly had a come up until the last few weeks. I mean, I'm still, massively pro-vaxxer, and I think most of the anti-vax stuff is sort of on the Jordan Klepper Daily Show end of the scale. But there is clearly, evidence that we're building over this and over the efficacy. I'll go to Mike, and then I'll come back. I'll tell you my Well, now actually I'll do it now because I'll do it now because it's relevant. So I went to Vegas to the HIMSS conference where I met a couple of colleagues of mine, friends of mine, who would not meet me in a bar, would not come into the hall, even though everyone there was vaxxed, would not basically go down. I don't know how they got to their hotel room, but were very scared to leave it. They had a suite in one of the hotels. When I got there, they made me take off my cloth mask and put on an N95 mask. And then they showed me the data. This is a company called Humetrics. They showed me the data of both some Israeli data they had, but also they had a big data set of Medicare data, which essentially was showing that even that the Delta variant, I guess what we all know now, the Delta, over the last couple of weeks, it's come out more and more. The Delta variant does infect people, the much higher vaxxed people, nowhere near as high a rate as it does unvaccinated people, but it does infect vaccinated people. In general, it's pretty good at stopping, the vaccination is pretty good at stopping the Delta variant, make people sick, avoids much less low rates of hospitalization, obviously much lower rates of death for sure. So, vaccination good, absolutely great. But what really struck me is that their data, which is interesting, suggested that there was no sort of waning of the vaccine, that pretty much people who got vaccinated were a month, 2 months in, were just as likely to get, who were vaccinated, were just as likely to get recurrences to get a breakthrough infection as people who had it 6 months, 8 months. It's hitting a lot of people. In fact, the editor of the healthcare blog, Christina Liu, who's just started medical school, first week in medical school in actual class, there was an outbreaking of COVID in her group and she got it. So, and she was vaccinated back in, I think second vax back in February or March. So we're seeing, stuff happen. And then I think we're now back to a couple of problems we raised here before. One is, okay, are there side effects with, these groups and whatever else, and how small are they, how tiny are, what are the risks? Can we keep people masking? I mean, my school district in Northern California, all the kids are going back in mask. We don't yet have a vaccine for under 12s. It seems to be fine. I just joined a climbing gym to make myself healthier. We have to wear a mask while we're climbing. It's okay. It's not great, but you can do it. But as you're talking, Anish, a lot of this stuff is moved from the scientific to the political, right, into the quasi-religious and cult-like, on both sides. Certainly on the anti-vax side, but to some extent on the other side. So I think we're going to have to figure out multiple strategies. And part of the thing about monoclonal antibodies is they're experimental, right? And Trump got them and Giuliani got them, but most people aren't getting them. So how is that going to play out? Anyway, Mike, what have you been looking at the last couple of weeks?
I'm sort of in the same situation as you are, Matthew. I mean, what's amazing to me is this pandemic has just caused a avalanche of existential questioning amongst at least American citizens. I don't know about the rest of the world. This week, I'm sort of trapped in a whipsaw between the extreme future and the extreme past. The future being, I had an op-ed this morning that focused on evolutionary biologists and what they are predicting will happen next after Delta. And they focus primarily on its infectiousness, its virulence, and the capacity for immune evasion. And so the piece that I published this morning had to do with the Darwinian movements of this microbe and how, on the one hand, infectiousness and virulence has worked very well for Delta, but on the other hand, it's putting the microbe into a corner in that it's going to run out of victims because it is so infectious. On the other hand, the tendency for the microbe is if you have a mutation that increases your infectiveness and virulence, it tends to decrease the capacity for evading the human immune response, and vice versa. The alpha variant, for example, began to show immune evasion capability, but it didn't have much infectiousness. That's why it was overtaken by Delta. So in any case, it's interesting to get now into the mind of these evolutionary biologists who are trying to advise us what may happen next. But what they all agree on is that if you give this thing too many rolls of the evolutionary dice, we could be in trouble. So a guy like Ron DeSantis is an idiot to do things that would allow this microbe to have a free hand. So anyhow, that's the future side of it. The past side of it is that I'm in the final stages of a course that I'm teaching this fall on the right to health care. And that's gotten me kind of knee deep into the Constitution, which you'd say, well, you know, what does that have to do with the predicament we're in? Well, I've been reading about the Federalists and the Anti-Federalists and their battle over establishing the Bill of Rights and the arguments for and against that, and the fact that these Federalists, which were mostly, you know, kind of big city guys who wanted a big national government, they wanted a strong federal court, they wanted a power to levy taxes so that they'd be able to get what they wanted to happen. They wanted commercial control. They wanted to federalize militias. They were opposed, as you know, by the Anti-Federalists, and these were mostly agricultural people, mostly from the Deep South, and they wanted the exact opposite of all of these things. In any case, what makes it kind of interesting to me, at least, is the fact that on one level, this battle that we're having with DeSantis, with Abbott, and all the rest of them is really nothing more than the same old 250-year-old battle over states' rights. That's what it is. It was never, the course that I'm teaching basically makes the case that it was never, ever resolved, but that if common sense were to dictate, you can fight all you want about whether healthcare is a right or a privilege, but the reality is it's a necessity. And the question is, all right, we can understand why and how we never got past this back in 1781 and 1787. But, you know, it doesn't cut it anymore. So basically, I'm kind of stuck somewhere between future and past. I'm hoping we can somehow break the logjam on this whole mess.
I would jump in on a moment on that. I thought it was really, really well said, Mike. As I listened to you and as I listened to what Anish said, I thought about the American character. Now, first of all, by the way, the people who believe in states' rights and local control don't seem to believe in local control when it goes against what they want to impose on localities. So they're not quite.
And to be fair, vice versa, right?
Vice versa, right. Absolutely. But so what do Americans believe in? Well, we believe in freedom and no limits, right? Keep on moving west, that whole thing. And we believe, since the advent of modern medicine, in cures, right? We'd rather have obesity surgery than eat right. We'd rather have right. And so, Anish, when you talk about the antibodies, the monoclonal antibody treatment, I think the reason the public health people talk about masking is they're trying to overcome a bias that says we don't need any prevention, which Mike just showed is going to stop the thing from spreading. We don't need any prevention because if I get in trouble, I'll use my cell phone and they'll come helicopter me out of the Grand Canyon, or I'll go to my hospital and they'll give me the same cure that Trump got. And I don't care about costs. And damn it, I don't want to pay any taxes. I don't want my health insurance premiums to go up, right? And so politically, it's so difficult that the public health people are stuck sort of talking about that because you're trying to change a public bias towards it'll all be okay. I don't have to worry. We're a great big country. I can escape it. It won't come to my town, et cetera, et cetera, et cetera. And that's kind of what DeSantis and those people are playing to. And what we have lost, and we had some before we got more, some of the partisanship was a sense of we're all in this together. And so what you have is, when you look at the libertarianism, when you look at what Friedman really said, he said, in case of a epidemic or pandemic or infectious disease, that's the only reason we needed to license doctors, right? The libertarian of all libertarians had some common sense, right? And that's gone away. Just like Ronald Reagan in Morning in America, everything's going to be okay. Reagan had common sense when it came to, real life. And what we have now is individuals who don't have common sense or don't want to use their common sense in public for political purposes, and therefore play to the bias of, we have cures, everything will be okay. I don't need to do this. I hate science except when I need my cure. I hate insurance companies except when they're going to cover my cost, right? And so that American character of freedom and everything will be okay, is really what the pandemic has unfortunately caused some people to not go to the common sense side of American character. And
Let me see if I want to try and square three.
Whereas Europeans, based in European history, know that everything is not going to be okay. Somebody's going to invade me. Somebody's going to take over the country. Somebody's going to kill all of us for whatever reason.
No one expects the Spanish Inquisition.
Or we'll leave the European Union and wonder why there are no employees, why there are no people.
Why we can't buy
lorry drivers left and there are the shelves and supermarkets all empty. Let me try and cram three things together, and I want to Jess in a second, and then back to Anish. So there's the kind of big question is, were Americans always crazy, or is there something new in the last few years? Right? There's that question. There's the can we cure everything after the fact question, and Jess has an interview today on the healthcare blog right about that, and then kind of back to the scientific one that I come from Anish is like, okay, what do we know about the vaccines, and what's the prognosis of that, and maybe these things all kind of come together. Jess, can you just talk about Calibrate, because I thought this was a fascinating, just a fascinating concept of a company that got $100 million to do. Well, tell us to what it did.
Yeah, so they got $100 million. They just closed their Series B. They've been in business for a year. So this brings the total they've raised up to $127 million. Guess what they do? Obesity.
What let me guess. Is it something to do with this part of my anatomy?
Hey, I still like that shirt. So no, they are a weight loss company, and their model is really interesting because immediately you hear that, at least I did. And I'm like, oh, it's like Noom, not like Noom. It's not a Noom. This is like completely different. So they have created a business model whereby they help people find, and then they prescribe a class of weight loss drugs that are called GLP-1. I'm not going to say this correctly. Agonists, is that right? Where's our doctor down there? Is he nodding? Okay, good. So this class of drugs, there's 11 or 12, 10 to 12 different types of drugs in that class that do this. They're injectable, $600 to $1,300 a month for these drugs. They're typically used for people who have diabetes to help them lose weight, and they're very effective. So I guess in clinical studies, the latest one to get FDA approval is a Novo Nordisk drug called Wegovy. And so it's like there's like a resurgence of interest in this type of pharmaceutical specifically for weight loss. And it's coming off of the fact that now the AMA is recognizing obesity as a chronic condition. So you see how this is all coming together. Well, Calibrate has built their business model around this, where people sign up for Calibrate. They pay for the Calibrate services, which is the access via telehealth to a doctor, to coaching, to a lifestyle intervention program. Calibrate helps them figure out which of those drugs is best for them, and their software helps them figure out which one is covered by their insurance. So the health plan pays for the drugs, the customer pays for Calibrate, and everybody wins. So yeah, you can see why they raised $100 million, right? I know. So yeah, this is pretty incredible stuff right here.
Oh, wait, are you being serious?
Yes.
No, she's being totally serious.
No, I made this up. That was pretty elaborate for our business, right?
We have always been crazy.
I find that business model to be ridiculous.
That is their business model. And it's $127 million in just a year of operation.
You're a cardiologist and you don't get that American healthcare is like jacked.
No,
I mean, look at their...
No,
175 million people are obese in this country. They have a huge TAM, and they're planning on taking this like drug plus behavior change model that they've built and applying it to other things like cholesterol or diabetes or hypertension. So it's like, if there's a class of drugs for this, go there. They'll help you figure out which one is right and also covered by your insurance. And then
medications for everyone.
Exactly.
So Anish, please. No, go ahead.
Tell me.
I kind of see it as a bit of a. I don't want to be too. I mean, I think it's a little bit of a scam. I mean, it's playing on the fact that, look, I run a diabetes clinic every once a month, and I prescribe. I can open up my fridge to show you the samples that we have of one of the GLP-1s, which is semaglutide, which is used and has been. It was it's a diabetes drug. They're incredibly effective. And they're not, the key to them, which was so awesome, is that they're not insulin. Insulin used for diabetes has all sorts of other side effects. And plus they have to be done once or sometimes 4 times a day, right? Where people are.
These all sounds like benefits. Where's the scammy part?
But you're talking about T1, you're talking about T2D, right?
Yeah,
and it's not T1 because T1, they haven't been bit. Well, I mean,
these might not even be diabetics at all.
No, but that's the point, right?
So these are drugs that came up for the treatment of folks who were insulin dependent, who have diabetes, and they're far superior to many of the classes of drugs that exist right now that we use to treat diabetics. They're superior to the oral ones in terms of how much you can lower the blood sugars. They are superior to insulin because you don't have to use insulin, and you can use this and they're once a week. And on top of that, they have been found at higher doses to result in weight loss too, which is amazing because insulin has absolutely not been found to be involved in weight loss, and actually you get weight gain. But hey, guess who should be having a conversation with you about these things and talking to you about all these things? And this is what I do at least once a month, if not more. Once a month, we run just a pure clinic for folks with diabetes. And right now, until recently, it was kind of off-label. There was just a drug that was approved, which I don't know if it's semaglutide. I don't know what the generic, what the brand name is for it. But that being said, so that's coming next. And so that's what we're excited as physicians to be talking to our patients about, because it's all related, right? Like, I'm a cardiologist, but guess what you have to do, in order to prevent cardiovascular disease, you want to work way upstream as opposed to working, playing into Mike's point about treating versus prevention. Hey, I'm a preventative cardiologist. Lipids and weight loss and diabetes control is a large part of preventing some of these complications. But that really should be done by somebody that you have a good relationship with, meaning your primary care physician, if your cardiologist runs a clinic like that, your cardiologist. So those are the people that really should be doing this. And this is just an end around.
These are clinicians who are doing this. They're clinicians. It may not be your primary care doctor, but it is a clinician. Weight loss specialist.
They want to insert themselves for cash into this because you have to pay for this, right?
Yeah, out of pocket. Consumer pays for it. They figure out how to get them the right.
But let me interrupt you. There's 2 things going on. One is, how's this getting on? So we're seeing, rightly or wrongly, a ton of venture capital come in to realign the, create a new primary care / specialty care model, whatever, which may work. In this case, they pick one thing. The second thing, and you tell me, Anish, when you go from people who have insulin-dependent diabetes, which is a large number of people, right, who are already under the care of a cardiologist, but that's nowhere near. If I look at myself, Sally, Raj Agarwal, who hasn't been on for a while, who just left Jefferson, is now at a company called Panda. But right, I was kidding with him because he's a gastric bypass surgeon, right? And I said, well, how bad does my gut have to get, Raj? He says, is your BMI over 40 yet? We're talking about these kinds of expensive drugs you'd expect would be pretty much for people who are on one end of the scale. By the time you're saying anybody in America who's above BMI of 26, 7, 28 should be on a drug that's $1,000 a month. I mean, that seems to be a big change. So whether or not it's an end around to go around people like you versus how many people are we going to start dealing with, saying instead of try and actually eat some vegetables and go for a run or whatever the
right. Because that's working. That's totally working. Right.
Right.
And like, in all fairness, like, and I'll say this, like, cause I asked, Isabel Kenyon, the CEO, it's like, cause it has like a weird feeling, right, around it, like this whole thing, but it's like, what they're really focused on is, the fact that people do talk to their primary care doctor about it. And the doctor says, exercise, lose weight, sleep better. And they've got a lifestyle component to that, but some people really do want to take a drug. And it's like, they're figuring out how to do that.
Let's go to Anish.
Okay.
And then to Casey.
I know.
Go to Anish first and then Casey, right?
I have real issues with the drug. I was just the one who said that, hey, monoclonal antibodies, that's the data.
Yeah, I know.
My point is, you need the drug. And then there's a larger systemic issue about lifestyle and how do we get Americans to be healthier, blah, blah. I get all that. But when you're in the room with a patient who has a BMI of 35, they have type 2 diabetes, they're on the path to having complications, cardiovascular, kidneys, eyes, etc. We try to do the best thing for them, and sometimes the best thing for them is a drug. So I got zero issues with the GLP-1s and the SGLT2 inhibitors, which are awesome. And like I said, I'm out front, and we're using them very aggressively in our diabetic population. And we will try to use them in the appropriately selected obese population. My issue is that this is basically an end around a dysfunctional healthcare system, and instead of trying to fix some of the issues that lead to primary care doctors not having the time to have a good relationship with your patient to talk about these things, that's what we should be focused on. And instead we get Roman, which is like call this line to get your Viagra. Like, why aren't you calling your primary care doc? It's because and that's because of problems in our healthcare system, which are created. It's the same. That's my issue with this.
That's what all of health tech is. Hi.
Right. So it's
to work around the broken system that is. I mean, at the top, when we were talking about Ginger and Headspace, that is to work around the fact that currently the mental health care system is completely broken for the people who need it. And it's unaffordable. It's inaccessible. There's a lot of stigma attached to it. There are a limited number of direct-to-consumer options. I mean, all of that is there. We felt good about that, but the weight loss thing, we don't feel so good about.
Instead of creating payment models that would actually make sense for psychiatrists, you create this albatross, which again, there's got to be some return, right? Where does that return go, right?
Venture capitalists.
Right.
Well,
exactly. So you're adding this layer of profit. So how are we ever going to get to a point where things are more efficient, better for patients, and by the way, also create a robust, healthy physician workforce that it's able to take care of all of you when your BMIs are 45. All right. Sorry.
I see Casey screaming. So Casey,
Hey, I'm taking the floor, and you're not getting it back until I'm done. Right?
Okay.
Until
Good,
I'm
go.
finished. I'm going to be finished when I'm finished, and I'll let you know. All right. Well, I agree that the system is broken, and I agree that it is broken in ways that defy fixes so far, and everybody has to figure out some kind of an end around. I'll start because this is where Jess sort of kicked this off, and then Anish sort of brought in a couple things. So I'm going to try to bring this home here. The biggest problem is that the people who need it most, the people who are disadvantaged, who don't have smartphones, maybe they've still only got a dumb phone. They could text with somebody, but they couldn't really do anything with an app because their phone doesn't do apps. And oh, by the way, they have 5 jobs at minimum wage, and they still can't pay their rent. No, they don't have insurance. If they need healthcare, they have to go out and pay for it themselves. So let's see, the Ozempic, sorry, let me say it correctly. The Ozempic ads that sing, Ozempic, and tell you to go to your doctor and talk about it. Even with a coupon from GoodRx, that stuff's going to be $900 a month. And of course, there will be a pharma coupon to get it as low as $25. But pharma isn't going to want to talk to you if you don't have insurance. So, okay, moving on. Then the monoclonal antibodies that Anish also brought up for COVID, which is a really big problem in our healthcare system lately, in case you hadn't noticed. Well, that 6 vial course of treatment of that, because it's not just a one-off, is $2,300 and change at the point of care in the hospital getting the monoclonal antibody. And sure, it's free Well, maybe to the person who has insurance, but if they don't have insurance, they will be paying at least $1,000, probably closer to the 25, but they'll be put into collections by the hospital that probably won't see them because they're probably already in collections for something else that happened last year. And then the vax is only $25. And that's even if you have to pay for it, which you don't have to pay for it because the federal government is getting that. Now, okay, Anish, I listened to you for a while. You're going to listen to me, all right? You're going to listen to me. I agree. I do not disagree with the idea that people need things like Regeneron and in some cases like Ozempic. One of the things I want to make clear to any patient advocates or members of patient communities that are listening to this right now or watching this later on Zoom, that Ozempic for type 2 diabetes, this is not for people with type 1 diabetes. So if you see somebody saying something on Facebook about diabetes and they're a type 1 and you start lecturing them about how they should just talk to their doctor about Ozempic, don't be confused that they give you a virtual knuckle sandwich. So but I'm so frustrated by all of this. Yes, the workarounds, but the workarounds, some of the people that end up the most expensive in the system are the ones that have no access to care. So they don't even have smartphones. So what are we doing for them? Are we doing anything for them? I'll shut up now.
I'll say one quick thing. Immediately before this, as you know, plug time, Jess and I are running a conference called Policies Taking VCs coming up.
Which I have tickets to.
You can find, which you're coming to. What'snexthealthcare.com is the website. Indu, my business partner, was supposed to be doing a business partner, health to an partner, was supposed to be doing a session, which unfortunately couldn't make some family emergency. So I did it with 4 good liberals who are now all running venture capital backed firms aimed at Medicaid. And they all basically said, one of them straight up said, I was working on single payer legislation. I couldn't get anything done. And I figured out this guy who started City Block Health, which is a new primary care clinic aimed at Medicaid and difficult, vulnerable populations in Brooklyn and, other poor neighborhoods, and it's raised like $500 million to do this. So, incredibly well funded. And,
I don't think
he said exactly something. It's an incredible workaround. We shouldn't have done it this way, but we've got to get stuff moving. And I couldn't sit around and wait for the rest of my life for someone to get the perfect federal policy that, takes care of all the stuff you're talking about. So I kind of get that. I do think that there is, what Calibrate is doing, which is, can we make a friendly consumer wrapper around something that probably should go through Anish? And I would guess, Anish, that if I walk into your clinic and say to you, I've got 20 pounds I need to get rid of. Could you give me the drug? As opposed, I would suspect you would say to me, tell me what you're eating. Tell me how you're working out. Like trying to get me going that path first. I don't know. But
so that's exactly what I was going to say. And it's really interesting that for instance, just to give you a couple examples. I'm sorry I talk so much. To give you a couple examples, there was a very expensive LDL lowering agent that came out about 3 or 4 years ago, right? Some PCSK9 inhibitors, right? Total, game changers in terms of how much they reduced LDL. Amazing. There were non-statins that reduced LDL a massive amount. All right, and so when they came out, the list price was some $30,000 a year, right? The payers, the insurance companies, balked. I would try to write them for some of my patients that had LDLs that were 120 and they had a heart attack and they're on max dose of statin and I need to get them to 70. And there's no other way. And the payers would be like, go fly a kite. We're not going to do it. Or they would say, here's 6 hours of prior authorization that you have to do. And I wouldn't have time. And over the course of a year, right, a year and a half, because doctors couldn't get it for their patients or doctors gave up writing it for their patients, the list price came down a significant amount. At this point, I don't have any significant difficulty at all getting PCSK9 injectables for my patients. But if the and this is where I think you needed someone to say, hey, you need some common sense. If somebody has a target LDL of 70, okay, and their LDL is 80, all right, and I want to write them a drug that someone has to pay $1,200 a month for, all right, the payer is going to say, I don't think so, because your marginal benefit, your benefit that you're going to get for going from 80 to 70 is pretty darn low. Now, if this person's LDL is 130, they've had a heart attack in the past, okay, maybe that's nice. So the same type of thing is probably going to happen with SGLT2 inhibitors for obesity, because as you're saying, there's way too many people with, I mean, my BMI, I think, is over 25. So you can't just have a BMI of 26, 27, 28, or 30, or, so there's going to be differentials, which is, different differential, there's going to be people that are not going to just pay, payers aren't going to just pay for that. And I think that'll eventually result in, what would happen if we didn't have this kind of third-party payment market. The other thing is, the thing about Regeneron, the reason I started waving my finger at Mighty Casey about the Regeneron is that Regeneron was actually, all the doses were bought up by the federal government in January by the prior Trump administration for the tune of $2 billion, $2,100 a dose. So all the clinics that are
and that's not going to be passed along in the form of, whatever at all.
No. So it's free. So if you go to get Regeneron is paid for by the federal government because it was considered so important, so it's paid for. So you should not get any bill for getting the Regeneron. The hospitalization costs, all that stuff, that's a different matter. But that's why they're outpatient clinics. That's why DeSantis is doing a tour right now, running around saying, hey, come to these clinics. They're completely free, completely paid for. There are no copays even.
So even if some guy washes up in a Florida hospital and he's the CEO of something and he's a Trump-loving guy, and they're all dudes, mostly. Anyway, and he washes up in an ER and he's got gold-plated, platinum-plated insurance. They're not going to bill his insurer at all for that?
Regeneron is paid for already by the federal government. If you build insurance for that, I think that would be fraud because then you would be doing twice. It would be like me building.
Okay, no. So in other words, they just get it free.
Let's not get into the technicalities of it. There are two things, and there's some weird stuff going on. I mean, in that my vaccine was billed to my insurance company, who sent me a check. I made a profit taking the vaccine, by the way. So
the
administration, go on.
The administration cost was billed to the insurance company, not the drug itself, not the vaccine.
Well, maybe they sent me a check, which blew my mind. But the question I want is my understanding is that there was a shortage of Regeneron. We didn't have that much of it, and that you had to be very sick and be a member of the cabinet or the president to get it initially. Or is that something else?
No. Regeneron. No, I mean, Regeneron and the other monoclonal antibodies that are out there, they're indicated not for every Tom, Dick. They're not indicated for 18-year-olds with COVID that are sitting around with a runny nose. They're indicated for high-risk people, pregnant, overweight, prior smoker, immunosuppressed, on chemotherapy, etc. There's a list of things that you have to qualify for to be high risk to be able to get it. But in terms of how it works, so I saw a patient 3 weeks ago or so who came in, who was a young man who was admitted to the hospital. He was just in his mid-30s. Who was admitted to the hospital, found to have new onset diabetes, was immediately put on insulin, a 4-drug regimen, and sent out. Right, and he saw me in follow-up because people know that I get people in pretty quickly. So we saw him about two days after he came out of the hospital, and we immediately put this young man who's now supposed to take 4 injections a day. How difficult can that be? And he's a type 2 diabetic, he's not a type 1. We immediately put him on some of these newer agents to get him off, and he got off beautifully. We had samples in the office, we gave it to him. Now, when he came back 4 weeks later, guess what? His insurance plan, he's in between something or the other. He has to pay $1,500 a month for, and this kid is like, once a week injections and a couple pills a day, and his blood sugars are like 65, 70, right? It's like, my goodness, now what am I going to do? Put him back on insulin? So we spoke to the pharma company, and we got him on some. We have him basically use samples to kind of bridge him to getting him to the point. So this is not a good solution, I'm saying, but just pointing out that that's what's happening in the real world in terms of some of these folks who really need it, in terms of how we try to. So if you have a good doctor who's an advocate, whether it be for if you have breast cancer and you have poor insurance or you're uninsured, my wife is an oncologist, like, you just got to find a good advocate. That's why, my big push whenever we talk about health policy reform is that if we can just empower physicians who care about their patients and let them do the right thing, a lot of good things do happen. Sorry,
Michael, come off
mute.
You're on
mute.
Wait. So what I really need is my doctor, who is an employee of a large health system, which doesn't let him talk to me anyway, to have the power to take time to make sure that a drug company is sympathetic enough to give me the drug if my insurance doesn't cover it, because I neglected to get the right job. And meanwhile, with all due respect, you may find that some of your colleagues are not really as interested in being advocates as you are, but some of your colleagues are, trying to see as many patients as they can to pay the mortgage, to pay the second mortgage, to pay the alimony, whatever. That, that's not a system. I mean, I'm just going to go back to.
I don't think that it's not a system, and that's not a good. These are band-aids that we're using. But my point simply is that if you I think it's a rarity, because again, the problem in us trying to be blasé about this is you're dealing with people's lives, right? It's like, I mean,
absolutely.
It's easy for me to just write for insulin, say, hey, see you at the door. But like, I mean, how do I get to this kid who's 36 and whatever? So
I'm applauding your compassion and smarts.
Most people are like that. Most oncologists are like that. Like, the problem is, I'll tell you what the problem is, Mike and others, is that the turnover for oncology, for instance, in large health systems is massive, right? The vast majority of them are like the good ones are heading to the world of pharma, because they're not on call on the weekends, they're not getting nighttime call, and they're not getting burned out by having to do 12 million things that have nothing to do with patient care in their thing. They're not getting enough support. So I think I think we're going to need some type of safety net for folks who are indigent and don't have care, whatever. And we can argue about how best to get there. But while we're trying to get there, it would be nice if we empowered physicians to kind of be able to do the right thing, not give them 10-minute slots per patient and whatnot. So, and I don't think the employed model.
I'm gonna Dr. Magee is my man on physician empowerment.
Yeah. Back in the late 90s, we did some of the earliest sociologic research on the patient-physician relationship. And the bottom line was, doctors aren't saints or sinners, they're somewhere in between.
Love that line.
Roughly represent the rest of the human population. And about 1 out of 3 that we chose for medical school, we chose poorly. If you use the marker of arrogance, we mischose 1 out of 3. 2 out of 3, we were able to train in empathy and compassion, understanding, partnership. And as a collective, along with nurses, they do a pretty damn good job in not only managing the direct healthcare needs, but also managing fear and worry in a society. So in general, they perform. But as I said to Matthew and Jess when they interviewed me about Code Blue, the book I wrote on the medical industrial complex, you got to step back and ask yourself, if we created this huge unmanageable healthcare system, this medical industrial complex, by basically after World War II saying, if you entrepreneurs can make a profit out of this, we'll support you, and unleashed all these forces that created this system that nobody else in the world uses, right? Is it really realistic to think then that the way we're going to fix this is through another round of profit-seeking entrepreneurs? Does that make any sense at all? I was saying earlier, that I was looking back in the past on history, and we were looking at system issues. And one of the ones that I was focused on was the fact that, we created these Articles of Confederation as our first run in 1776 out of creating a governance structure for this country. And very soon after we created that, George Washington raised his arm in protest, saying that this system was terrible. Now, why did he say this? Primarily, he said it was because he had no money. They hadn't built into the system any way to tax, and he had no resources. In addition, he had no control over defense. There were only 625 men in the army. Spain had closed New Orleans. There were Barbary pirates The Creek Indians were being supported by the British to support Georgia. There was a Shea Rebellion in Massachusetts. And on top of all of that, in order to change these Articles of Confederation, which they eventually did, you needed to have unanimous approval of all of the states, and you had to have both reps there. So if one of the reps couldn't make it, you were out of luck. So basically, the point that I'm making is you can say, well, we'll rely on good doctors and good nurses of good spirit to manage this broken system. Or you can say, you know what, we'll just infuse more money and more profiteering into this broken system, and maybe somehow they'll be able to flip it into shape. Or you can just admit that the system is effed up. It was from the beginning. We never asked the question, how are we going to create a healthy America? And we never created any sort of plan. And as a result, when a COVID comes along, of course, we're going to fall apart. What would you expect? We have no system. It never was created, So silver bullets and silver lining, okay, good, they work for lucky people, but that's not a system either. So you got to have a plan. We got no plan for health or for disease.
Mike, I'd agree. We're running a little on time, so I want to say two things. Right, one is, I talked to the guys at City Block, or some of these new primary care. Yeah, they're venture funded. They're going after Medicaid. They seem to, or some of the Medicare Advantage primary care groups, they seem to be doing the right thing, right? They sound like the people well motivated. They think there's enough where they can generate margin out of this and make some money for their investors. But what they seem to really care about doing the right thing, and maybe they can scale and expand. And a lot of these people, as Casey pointed out, a lot of the folks in those communities have, if they're not lucky enough to run into a niche, like go to bat for them. And as you say, at least 1 out of 3 doctors that may not be as as the niches, maybe, whatever. So there's a chance you could do that, but they all say, they admitted to me on this thing today. It's kind of ridiculous that that's the way it's been. We don't have a system. We don't have a plan. I don't see it. I mean, we may get a few hundred billion for care, some billions for caregiving coming out of the bill that Biden's putting through, if that gets through. But I don't see a system coming out of this that changes this. And we still have, what is the 253 billion locked in the reserves of the big health systems, who are employing the doctors that Michael's complaining about, and the ones that Anish say are leaving their systems and going to easier jobs working for pharma. So we're a long way from that. Now, I do want to change. Last sort of 2 minutes, where do we think go back to where we started with the vaccine either not being effective or the Delta being more, the Delta being better against it? The likelihood that, as my friend who's the chair of genomics at, my drinking buddy from college is now the chair of genomics at UCL. I don't know how that happens, but in London, he said it's a good vaccine. It's very clever. It's getting, it kills fewer people, but it spreads faster. That's what it's doing. Is it, as the next variants come around and get around, and the vaccines perhaps get less effective. I just love a minute or two from anybody who's looking at this. Like, where do you think with this? I know we have the politics of masking and unmasking DeSantis and all this other stuff, but where do we think? I mean, do we think we're anywhere close to getting enough people vaccinated this goes away, or are we going to be sitting through COVID and all its ramifications for years? Casey, then Anish, come on, quick.
No, this is going to be quick. This is, we've already, the horse is out of the barn and 3 counties over. I don't think we're going to get on top of this thing. It's going to be a combination of things that we're going to have to do. I'm sure that, treatment to reduce symptoms, a la the, Regeneron monoclonal antibodies, are going to be necessary to keep people from dying who get this. And I am going to continue to mask that. I've had 3 jabs. Hello, welcome to advanced cancer. But I think that science communication in general has been on #EpicFail for too much of this. It's very difficult to communicate uncertainty, and that is where science falls short. They need to get more people like me, frankly, who are good babblefish at interpreting the babblese that comes out of academia for the average human. So yes, that's a naked call. Go ahead and hire me. I'll help people understand WTF you're even saying. And but I don't think we're going to be on top of this. We're going to be living with this for a while.
Anish?
I would agree. I think it certainly seems like even in highly vaccinated places that have done really, really well, that UK, look at Israel, you have a significant spikes despite vaccination. I don't know about the whole NPI, non-pharmaceutical interventions, mitigation versus mask, etc. I mean, I don't really know and how massively effective they are at preventing spread of this respiratory virus, especially when it gets more transmissible, like it did when it went from Alpha to Delta, right? You look at the Pacific Northwest right now. Look at Hawaii, which is an island which has has been doing all the right things. Man, I think it is really, really hard to keep this thing out. And I think the only thing you can hope for is the vaccines do continue to decouple cases from ICU hospitalizations. Israel is showing that there's been an uptick there too. And that really starts to feel like, and I hate to say this, it really starts to feel like, the places that are most protected are the ones that have been hardest hit and have had high mortality, which means if you did a really, really good job of protecting your nursing homes, say in the spring of 2020, which New York didn't do for a variety of non-political reasons. I think it was going to be very hard in New York to do anything. I'm not blaming anything per se. But in nursing homes in Florida, you didn't have that much of you had somewhat of a more protected thing for whatever reason. It's going to be very hard to keep those folks that are susceptible, out of critically ill, out from being critically ill in ICUs. I think that's what this is showing us, that if you're susceptible, if you're over 80, living in a nursing home with multiple comorbidities, I don't know. The vaccine is as good as it's going to get, maybe, but then we really have to shift. This is why I said what I said initially. We really, I think, have to shift from not just vaccines, but also starting to think more about therapeutics here, because clearly vaccination by itself, we're not going to be able to get to high enough levels, and it's been shown in multiple different geographic areas now, to get to COVID zero. Like I don't think that's realistic anymore. So we're going to be living with an endemic virus that's going to keep having waves. And the best way out of it is to decouple cases, which is from ICU. And there's going to be multiple ways of doing that. Yes, get people vaccinated, but also we really got to start shifting to focus on therapeutics. And I'm disappointed when I hear public health officials say that the evidence for MABs and monoclonal antibodies is so, and it's not so good, and it's so expensive, and we shouldn't be using it, when I'm not, that's going to be a part of the solution.
Right. Okay. I'm with you. There's a long way to go here, and the new normal is not going to be back to 2019, very sadly, for those of us who like hanging out and foreign travel and drinking, which is what I was hoping for. All right. We're gonna be the real quick wrap up. We're running out of time, so real quick, just a sentence or two. What are you looking for in the next week or two as back to normal, Michael?
Well, first, I think that Mighty Casey and Anish really expressed what's happening pretty realistically, particularly when you look at what's happening in some other places. So I think that's an important dose of realism, and certainly the communication from CDC has been a C or a D. I'm looking to see that underneath all the absolutely justified worries about COVID, whether the bill that goes through with the Biden spending will change Medicare benefits, expand Medicaid, change home care. And finally, I couldn't help but listen to Anish about the decoupling of the ICU cases and the cases themselves, and wondering what venture capitalist is watching this and thinking, what a tremendous opportunity that is to have an app that we can decouple from your doctor and just put in, and maybe you can calibrate how well your health is and whether you're dying, and damn, there's some money to be made there. So I know that American capitalism will see this as an opportunity.
Absolutely.
Mike.
Well, I think with all the fear and worry and all the reactivity, people are tending not to look at this from a macro perspective. And what we're ignoring is the fact that part of what made us vulnerable to begin with was global warming, high-speed travel, and a healthcare system that's built on profiteering of multinationals. And all of those three factors still exist. All of those three factors are accelerating the checks and balances that we placed on all of those three elements, beginning with Reagan and extending right through Republican and Democratic administrations since then, have basically placed us in a position of extreme vulnerability. And so you can expect more of the same. And it doesn't matter how much you race with silver linings and silver bullets. You won't keep up with this stuff. You've got to go back and fundamentally put in checks and balances that are going to control the tendency toward overreaching and human greed. And you have to be able to make a strategic plan to manage climate and also manage the movement of people and materials in a way that is safe and efficacious. And without that, it doesn't look good for the human race.
I'm going to forecast for the next 2 weeks. All right. Next couple of weeks.
You know?
I am gonna end by raising Mike's blood pressure, maybe Michael's as well, and say that I think the American capitalistic profit-driven healthcare system has been the world's best hope for producing the most effective vaccines and as well as some therapeutics. And I am really hoping in the next and maybe not a few weeks, but the next months to come, that same drive for profit that can result in many bad things that the folks on this panel know very well will result in some breakthroughs that can help us make our way through this pandemic.
Well, you may be surprised that I totally agree with you, but my 2 points back are this. Number one, with it being so strong and so great, it doesn't need government relations and public government funding in order to continue to progress. It can do it on its own as a private venture, including the doctors who decide that they primarily would rather work for pharmaceutical companies than to take care of patients. The second thing I would say is, that said, it's still not a plan. Okay? Unless you can give me a plan, then, we don't have a government that's going to succeed.
All right. Casey, and then Jess, and then we're out.
Yeah, well, in the next 2 weeks, I would like to see some flattening of a curve somewhere. Haven't really seen it outside of maybe a little bit in New Zealand. Stay tuned for updates, but certainly not in this country. And I am also really looking for the system that Mike speaks of, because $4 trillion a year, people see numbers like that, making the Pentagon look like homeless people, by the way. And the healthcare lobby has no interest in giving up any of that. And that goes into way too many people's pockets and not into caring for humans. So I'm not convinced yet.
Jessica, you get the last word for what you're looking for.
Oh, I'm just going to stay here in Florida and continue to risk my life covering this space with my high deductible health plan that I bought on the exchange that I view as catastrophic, buying my sinus medicine over the counter and getting my occasional UTI taken care of through Lemonade by paying cash, and watching, venture capitalists pour some more money into this thing. Because, like Mike said, if the incumbents don't have a plan, I'm pretty sure that these guys do.
All right. Okay. So we ran over a bit today. I want to thank everyone for staying on, for those of you watching or listening on the podcast later. You have enjoyed another THCB Gang, our first one back from our summer break. We had a lot of fun there. Mike Millenson from the wilds of Chicago, Casey Quinlan from Richmond, Virginia, Anish Koka.
Your sizing is a little funky there, brother.
Oh, something weird gone with this. Well, hopefully it'll work out. I am sharing Jessica DaMassa from Jacksonville, Florida.
Risking her life in Florida.
That's it. And Mike Magee from Connecticut. So that is the all East Coast or Midwest other than me, THCB Gang. I want to thank everyone for watching and listening.